Great. Thank you so much, Dr. Jack, for that talk about peripheral nerve surgeries. And so our next speaker is Dr. Pavan Tankha, and he's going to talk about management of pain associated with neurofibromatosis. So thank you very much, Dr. Tankha.
Thank you. All right. Good morning, everyone. My disclaimer for the talk is I am not nearly as good a presenter as Dr. Jack, so I hope you all enjoyed the previous presentation. That being said, we're going to go over a lot of different things today. One disclaimer I do have is I am an adult pain management specialist. At Cleveland Clinic, we do have a pediatric pain management specialist. A lot of these options overlap, but not all of them. So I just want you to keep that in mind. This is primarily for adults, but there is a huge amount of overlap. And I'm the medical director for our comprehensive pain recovery program here. So let's first talk about pain. What is pain? Pain is an unpleasant sensory and emotional experience, resembling actual tissue damage or potential tissue damage. And so there's two things I want to highlight. Pain is simply not what you feel. It's also what it does to you, that emotional context. And the other part is pain can be actual tissue damage, a cut, a surgical incision, again, as Dr. Jack was mentioning, a tumor, or potential tissue damage. As many of you are well aware or may have experienced, you may have chronic pain in areas where there are not tumors. And so what is the explanation for that? Whether or not we can find what's causing the pain doesn't mean you're not in pain. So pain, sensory, emotional, actual, or potential tissue damage. And so just briefly, again, I don't want to bore anyone or put anyone to sleep before noon, but I just want to talk about pain processing. What is pain? How do we understand it a little bit better? So the first thing to know is pain is not a passive signal. Oftentimes we could think of it that way, right? You touch the hot stove, ouch, stop touching it. But in reality, it is much more complicated than that. There's a very complicated neurochemical review that occurs at the level of the spinal cord whenever there's a painful stimulus. And what that review dictates is whether or not we amplify the signal or quiet it down. Of note, when there's amplification of the signal, it's simply not the painful aspect, but also the emotional aspect as well. And so at the end of this complicated neurochemical review at the level of the spinal cord, you could either feel no pain or anything in between. And so this is important because we'll talk about shortly a couple different medications and how they work. If we can in some way interfere with the pain signaling process, we can reduce pain. And there are a number of ways we can do that. Briefly, again, let's just talk about the types of pain as well. There's three different types. The first type is the type I think all of us are familiar with when there's damage or irritation to tissues of the body. This usually involves inflammation. When the inflammation or injury gets better, the pain goes away. The other type of pain, which again, a lot of focus today will be about, is damage or irritation to nerves. Again, these nerves can be anywhere from the central nervous system to, again, our arms or legs or body. And there's actually a third type of pain as well, which I like to bring up. And this is a type of pain where there is misfiring of signals from the spinal cord up to the brain. And again, this is a type of pain that has always been around, but we've recognized it much more recently. And we see it with a number of different types of chronic disease conditions, whether it's organ failure, whether it's a condition like fibromyalgia, or again, different types of neurofibromatosis. So again, these are the three types of pain. Understanding these is important because the treatments for each of these are also very specific. So the question is, how do we approach pain? I mentioned pain is a sensation. It's also an emotion. How do we treat it? We use something called the biopsychosocial model, where we look at biomedical treatments, we look at psychological treatments, and we also look at social treatments. Essentially, what we're trying to do is we're understanding you as a person, simply not as a symptom. So how do we go about that? The first category we'll talk about is biomedical treatments. Arguably, one of the most important is this concept of self-care. Self-care includes nutrition, exercise, and sleep. Oftentimes when I mention this to patients, they roll their eyes and they say, "Doc, this isn't going to take my pain away." And I absolutely agree with them. This will not take pain away. But when these three are not optimal, pain can actually increase. And so to give you just some very simple examples, if you don't sleep well at night, more likely than not, your pain will be worse the next day. What we know is if you do too much, pain may get worse, but if you do too little long enough, pain also gets worse. And then in terms of diet and nutrition, what you eat doesn't necessarily cause pain, but what you eat can make pain you have worse. What you eat can make pain you have better. So optimizing and understanding these components of self-care are very key to make sure pain does not get worse or flare up. Diet, nutrition, and exercise. There's a number of different non-pharmacologic options as well. Again, in addition to the lifestyle changes with self-care, smoking cessation, there are different rehabilitation options, psychological options, integrative options, acupuncture, yoga, tai chi, massage, as well as pain education. What's the difference between harm and hurt? Actual and perceived disability, and pain and emotion. As I like to tell a lot of my patients, pain and emotion is processed in the same area of the brain. They're essentially two sides of the same coin, so we need to understand both in order to get patients the best quality of life. Let's talk about medications. There are a number of different classes of medications we can use with chronic pain. As I tell all my patients, all of these work, they just may not work in you. So I ask for a little bit of time and a lot of patience on your part as we cycle through to see which one of these agents can work. Again, there's the anti-inflammatories, right? That's the Motrin, Advil that you may have at home, acetaminophen, our go-to Tylenol. But we have other medications like the anticonvulsant medications, pregabalin or Lyrica, gabapentin, pregabalin. And of note, when we talk about that neurochemical review I was talking about before, we think these two agents lead to decreased pain signals going up to the brain. In terms of neurochemical review, the brain also decreases pain signals, and so that's where the antidepressants come in. Amitriptyline, duloxetine, venlafaxine, these can potentially also decrease the number of signals that go up to the brain. We have our muscle relaxants, again, topical agents. And again, while any one of these may be helpful, sometimes you can cycle through a number of them and they don't work. And I tell patients that's also okay. When you start looking into how complicated pain signaling is, while these are 6 different areas we can target, there are over 30 or 40 different receptors or pathways pain makes it up to the brain. But again, since these are safe, well tolerated, it's worth trying to see if they help. Oftentimes patients ask me, what about opioid medications? Hydrocodone, morphine, tramadol, can we use these for long-term chronic pain? And again, I mentioned there's very little evidence that opioids are effective in chronic pain. They're fantastic if you've just had a surgery for a couple of days to reduce pain, but long-term, they don't quite do what we want them to do. In fact, for long-term, we see there's actually a risk associated with them. And if you look at the patient's quality of life, a lot of patients are actually in worse pain, worse depression, more likely to be disabled. Interestingly enough, what we've also found is if you take patients on chronic opioids and you simply wean them off, you can actually decrease pain, decrease depressive symptoms, and increase function. So that's one of the hesitations I have about prescribing opioids for chronic pain. There is a medication, however, that a lot of patients have been asking about recently, and that's buprenorphine. It is one of the main ingredients in another medication you may have heard of called Suboxone. Buprenorphine is an opioid, but it only partially binds the opioid receptor, unlike the other opioids that fully bind it. It can potentially reduce pain. It's safer than conventional opioids, and in fact, the Department of Defense and the Veterans Affairs groups recommend it as a first-line opioid for patients with chronic or refractory pain because of that. So this is something you could talk to your provider about potentially trialing. And there's multiple formulations for buprenorphine as well. It's a tablet, it's a film, it's a patch, and so depending on what you can tolerate, that might be an option. Again, I'd like to just emphasize there is no truly safe opioid, but relative to the other conventional ones we have, this one is relatively safer. Ketamine infusions. Some of you may have heard of this. If not, it is something we offer here. Ketamine is an anesthetic. It's been around for 50 years. The last 40 years, we've been using it at varying doses for chronic pain. What we do here at Cleveland Clinic is we do a low dose infusion, a very low dose of this medication ketamine, and we infuse it over 40 minutes, 5 days in a row. And what we have found is at that low dose, it's very safe, and we can get a possible effect on pain by infusing multiple days in a row. Again, as I mentioned, safe. Side effects are no different than a placebo, or as I tell patients, no different than a tablet of Tylenol. And what we see is about 30% of patients can receive some benefit from this infusion protocol. So again, if you've tried conventional medications and they have not helped, ketamine might be a safe option to look into. How about injections? How about injections? Again, like medications, like the infusions, if you're a properly selected patient, these may be beneficial to you. There could be epidural steroid injections that are done. We could do specific nerve blocks to various nerves that are affected. If there are issues with the joints also in play, we can look at medial branch blocks or radiofrequency ablation. If there are very single areas of just muscle, trigger point injections where we inject the muscle can be effective. We have something known as sympathetic ganglion blocks if there is a sympathetic component to the pain, or you have refractory migraines as well. And then there's also perineural sheath injections that could also be helpful. So again, in the properly selected patients, these may also be options. I am heavy-handed with this next slide clicker. So how do we talked about the biomedical treatments. What about the psychosocial aspects of pain? And so there are 3 components that are very prevalent in patients with chronic pain. Patients have maladaptive thoughts. This could be the rest of my life. There were things I wanted to do. I'm a burden to others. That can cause psychological distress, depression, anxiety, worsening of symptoms of possible PTSD. This psychological distress leads to maladaptive behaviors, staying in bed all day, staying on the couch all day, being immobile, which over time can lead to more maladaptive thoughts. I'm now good to anyone. I'm just, again, a burden, which again, the cycle continues and continues. And so understanding this cycle is important because all 3 of these areas maintain disability. Another way of thinking of this is if we could target any one of these 3 areas, we can reduce the suffering associated with pain. And so how do we do that? We have a number of different treatments. We have cognitive behavioral therapy. We have emotion-focused therapies, social services as well. As I like to mention to patients, pain is very difficult to treat if you don't know if you will have health care in a couple weeks, if you don't know where your next meal is coming from, if you're living out of your car. Get a strong foundation in social services is very, very important in order to also grapple with chronic pain. And again, something we're very fortunate to offer here at Cleveland Clinic is pain rehabilitation programs. How can we address all these things in a unified manner in a program to help give you the skills to deal with chronic pain? So these are various treatments that are offered that can be beneficial. Oftentimes people ask me, all right, well, how do you approach everything? What are the steps? And it's pretty simple with chronic pain. The first and most important is you listen. I've been doing this for a while. No one has ever made up their pain. Whether or not I can find where the pain is coming from is a completely different issue. But I believe, again, pain is real. So it's important to listen, figure out what's going on and how the pain is affecting everyone. Optimizing self-care. Again, as I mentioned before, these don't take pain away, but if it is not optimal, pain can get worse. So optimizing self-care, very, very important. Doing a biopsychosocial evaluation. Let's talk about medications. Let's talk about possible injections. Let's talk about the suffering and whether or not you need to see a pain psychologist or a more formalized program. Again, pain is what you feel, but it's also the suffering it causes. Let's try to address both of those. And making a plan. Making a plan is very, very important. I try to do that with all my patients. What are the next steps? When will you see me next? where are we going from here? And finally, arguably the most important is hope. Progress in medicine is slow, oftentimes very incremental, but there's always hope. There's always something around the horizon. And again, when one of my colleagues asked what I'm doing on Saturday morning, I mentioned I was giving this talk, and I think it's very important to know that the different providers I work with are so motivated in helping our patients. And again, we all have this hope that there are new treatments that'll come out to reduce suffering and improve quality of life. That's Sadie. So if you're wondering what I'm going to get back to when I go home, it's probably her nap time, so it's going to be great. And I believe there'll be time for questions later, but thank you for your time this morning.
Great, thank you, Dr. Tankha. Yes, so if you have any questions for him, please enter them in the Q&A box, and we have a panel discussion that's happening around 12:20 that we'll try to kind of get to these questions and answer these questions. All right, terrific.